Thank you, Professor Atul, for a very generous introduction. You've always been very kind. Maybe we've been so long together, trained together in USA way back, which goes all the way. Maybe it will go close to 30 years now, maybe somewhere. Thank you for making me part of this prestigious course. Uh, I'm just going to show you perhaps some cases. That's the way Professor Atul wanted me to show some real life situations. Of course, I think all of us, we are aware now of the non-center and center involving. Non-center is something like this, and but what I'm supposed to concentrate on is the center involving diabetic macular edema like this. So this new classification, this has become very, very important. In fact, that's how we are treating and monitoring our patient these days by doing a OCT, and this is the OCT classification. And the way we proceed, which we never forget, that this is a systemic disease. So any diabetic macular edema patient must have blood glucose levels, blood pressure, lipid profile, hemoglobin. HbA1c is very, very important. And so is the 24-hour urine protein or microalbuminuria, and also blood urea and serum creatinine, usually in later stages, because that is a parenchymal damage. So we usually, in the beginning, we tend to do fundus photo OCT. We may schedule a patient for FFA usually, because most of the time FA is not possible immediately. Ultrasound, of course, is required if your media is too hazy. And so we initially, we target for an excellent glycemic control with our physician and endocrinologist, normalize their blood pressure, reduce their serum lipids, as well as treat anemia as well as proteinuria, because all these are is possible. And if we do that, we do a lot of good to the patient as such. And subsequently, we go on to intravitreal anti-VEGF or steroids with or without laser subsequently, which may be followed, pars-plana vitrectomy for a taut hyaloid case, or sometimes the combination therapy. I'm just showing you some cases here. This is one published from our center way back. Just using the lipid and metabolic control, you can see from count finger, this particular patient down the line was 612. Everything did go away, and that is this is before your anti-VEGF era. So, and we did this study published in Diabetic Care way back. The multifactorial intervention before laser photocoagulation improved outcome of DME. You know, ETDRS had just got a very something like 3% visual acuity improvement. In that time, we got almost 30% visual acuity improvement. So that's how we aimed for multifactorial intervention. I'm showing you from that era only one of this example here. And along with a strict metabolic control, controlling everything which I mentioned in the early phase, just in 3 months, date is there, you can see, and this is way back in 2006. The hard exudate has melted away, edema has come down. We have not done any laser. That time, injections had not come in as yet. I think we started using in India sometimes in 2007 beginning. This is another similar situation here. You can see how well it has gone away. And of course, anti-VEGF. So I'm just trying to put what has been shown in the Cochrane review here in 2017, that anti-VEGFs are effective in improving vision in DME in 3 to 4 in every 10 patients. That is the way it is. And it may be something like 3 or more lines. So most are often under-treated and under-monitored. This is what happens with DME, which doesn't happen often with AMD. And this is absolutely true for our population. The overall safety between the 3 anti-angiogenic drugs appears same. So this is what this particular Cochrane review says. I'll share some patient because I'm supposed to talk on real life situation. 58 years old male here. Again, you can see everything was wrong with him. I'm not putting the values here. So put on strict metabolic control. Look at the fluid, amount of fluid here. And with metabolic control, the fluid came somewhat down. And then subsequently, we gave 3 injections of Avastin, followed also by grid laser. You can see everything kept on going down. I'm sorry, this OCT is reverse here. The last one is the one which is on other side. So you see, in such a situation where you have such a bad picture, if you don't do everything possible, it's not going to work. What about corticosteroid? Considered essential adjunct for treatment of the refractory and persistent DME. Efficacy is comparable to anti-VEGF in pseudophakic eye, so we are very confident that use many a times as an adjunct for cataract surgery worsening in DME. And the problem is cataract and raised intraocular pressure, which are major side effects, and it worries us. You can see a patient like, again, one situation, 60 years old. Again, you see even the triamcinolone 3 has been given in past. Still the edema is like that. Only 13 letters patient reads, and it is 451 micron. Just giving during the surgery, during phaco, Ozurdex, you can see the result here, 45 letters, 236 micron, the edema is gone. So it works like a magic in some of these cases, as well as it would not only take care of, because first 3 months are most important. Another one, I think this patient received everything. I have not even put that here. Avastin, perhaps 5 or 6 injection, even we had given here triamcinolone, and also the laser, you can see how much grid has been done. So with Ozurdex here, it showed a remarkable response. So refractory diabetic macular edema, this is something I think at this time we have to know this, that the treating diabetic macular edema in a real world, this is a UK clinical outcome, and this is a recent one with the something like a Iluvien, and this you can see here. I think that is what we see, number of studies. I've just projected one here. I think it has a sustained effect, and many of these cases which previously and otherwise which are chronic or refractory, they show very good response. I'm going to share you one case which was in our trial here. This is 60 years old. You can see 2 lasers, 3 Avastin, and he was given Iluvien by us in 2006 in a trial. And you can see here, in 3 years, everything dries out. And this was a picture taken much later when we were out of trial, 5 years. It looks as if nothing existed there. So I think some of these cases definitely we need to have steroids like that, especially in our situation. And that is what would be very important. And it's not, even if it is expensive, it will, like we talked yesterday only, it is more cost effective than giving your repeated anti-VEGF. So DME surgery, beneficial for the functional anatomical outcome, intractional DME. Routine ILM intractional DME is still a debatable point, but many people do it. And so I'll just again share with you one case here, 72 years female, came to us in 2009. And through 2011, you can see here, she has received 624 vision and grid laser done. She was given 5 injection Avastin. Still, the edema would persist there. She was one perhaps very reluctant for surgery. You can see she had all along shown that tractional edema. So here she finally agreed. And once she agreed, you can see this is after the pars plana vitrectomy, removal of the membrane. You can see the membrane is not there. And subsequently, you can see she still improved to 612. So this is, you see the laser which we have done earlier. You can see that on autofluorescence there. But I think surgery in such a situation is very much required. So, well, friends, I think Professor Atul already mentioned about economics in diabetic retinopathy management. I think it is very difficult for us. Individual pays in India for treatment. So we have a very difficult situation. Insurance coverage and government support is limited, and treatment varies according to the cost involved, affordability, and diverse Indian scenario. We have to many a time, even today, do a traditional laser treatment or use maybe 2 milligram triamcinolone, and they may not even afford even sometimes Avastin, what to talk about the anti-VEGF. So I think we have to really kind of weigh everything and should not forget. So the standard of care comes with some rider to be followed despite these problems. So I already mentioned, this is even the experience in Cochrane review. These are often undertreated and under-monitored. They also have a lot of systemic issues, we should not forget. So in conclusion, I would say comprehensive control of blood sugar level, blood pressure, proteinuria, anemia, and lipids improves outcome of DME. I have shown you some of those pictures which we have been showing for years together, which really brings out that it works very well. Anti-VEGF steroids alone or combined with laser is preferred than laser alone in diffuse or center involved DME. So laser at this time exclusively is only for the non-center involving DME. Otherwise in combination it can be used. Laser is required for control for the center involved DME along with anti-VEGF to reduce number of injections. And the vitreous surgery is required in tractional DME. So thank you very much, friends.